Well, good afternoon. It's 12:15 on January the 15th. Happy New Year. My name is Wendy Farthing. I am the deputy of the MAC Incorporated Maryland Living Well Center of Excellence, and welcome to 2026 with our webinar series from GWEP, Ask the Dementia Expert, our Lunch and Learn series meeting monthly. Today, we are going to be talking about the overview of medications to treat dementia and Alzheimer's disease. This topic was so popular in our registration that we are splitting it to be able to be responsive to all the questions that we received that Dr. Nidada Volu is coming back in February to assist us with diagnostic testing for dementia and stages of Alzheimer's disease. Before we get started, to remind everyone to please visit our website for additional workshops for caregivers that we've started and are hosting. We have a robust series that monthly between building better caregivers and powerful tools for caregivers. So we hope you are able to join that. So next month is February the 19th, where we'll be doing the diagnostic testing for dementia and stages of Alzheimer's disease. For some resources, we are an active STARS state, and we are still recruiting folks to participate in the lived experience panel. So these resources will be sent out to you after the webinar. For sign up, there's a QR code to access a SurveyMonkey. We are looking for 5 individuals with mild cognitive impairment or early stage dementia, as well as 5 caregivers, care partners, unpaid family members, or friends supporting someone with dementia. It's a year-long commitment with quarterly virtual meetings and a review of materials, and there is an honorarium up to $400 upon completion. So for more information, you can scan the QR code or go to this SurveyMonkey and sign up, or reach out to Carrie Finnegan with the Alzheimer's Association to answer additional questions. Our partners with the Alzheimer's Association also have various resources on our website. We've done some collaborations with them, so I encourage you to check that out. And without further ado, I am going to introduce Dr. Lolita Nidadavolu, Dr. Nee. She's a geriatrician, has clinical expertise in the evaluation, diagnosis, and treatment of older adults with memory issues and dementia. After earning medical and doctoral degrees from the University of Pittsburgh School of Medicine, she completed her residency training in internal medicine at Brown University and fellowship training in geriatric medicine and gerontology at the Johns Hopkins University, where she's also completed a postdoctoral fellowship in translation agent research. So without further ado, welcome. Thank you for joining us.
Yeah, thank you again, Wendy, for this kind invitation. And again, I've got a very broad topic here to cover, talking about medications for treatment. So hopefully there's some time at the end for some questions also too for those in the audience for things that I haven't brought up. But again, I'm glad that we were able to coordinate a follow-up session in next month to be able to just really address all the questions that had come up from those who had registered. So next slide, please. Great. So again, I don't need to necessarily go into this in too much depth for this audience, but just wanted to reiterate that dementia is a very broadly defined term. It's not, it consists of a series of different conditions that are listed here. One of the more common ones being, Alzheimer's disease, for example, but Lewy body disease, frontotemporal disease, vascular dementia, Parkinson's disease can all progress to what we call dementia, which is when the memory issues that someone has or cognitive ability decline leads to functional problems. And that's when they're serious enough to interfere with everyday activities. Again, 60% are typically due to Alzheimer's disease. And I think because of that, a lot of the medications I'm going to be talking about are really oriented on and focused treatments for Alzheimer's disease. So the big caveat I'm going to give at the beginning of this talk is that we know a lot more and have a lot more Alzheimer's disease specific treatments that are currently available, especially the latest ones that I'll go into. But there is still much more to learn, much more coming down the pipeline for a lot more drug discovery. So it's my hope that my work as well as my colleagues who are doing research can come up with more therapies so that we can give an updated talk in a few years and have new treatments to talk about. So next slide, please. And so again, we now have a follow-up session to this that's going to talk a bit more in depth about the progression of Alzheimer's disease and other diseases that can cause dementia in general. And I'm just going to bring this up here just in talking about the medications because as we know from treatment and learning about Alzheimer's disease and other dementias, when we are able to give treatments that can change the course of disease earlier on. So again, in this mild cognitive impairment stage, that those are the treatments that tend to have the biggest likelihood of having a bigger impact on someone's overall function compared to if someone were to take a medication at the moderate or even severe disease state. And then again, just the severity of dementia can really be characterized by some of the items listed here, where there can be more disorientation, mood changes, and ultimately leading to difficulty with speaking, swallowing, and walking. Next slide, please. So here's a bit more of a scientific breakdown of some of the things that we know of that are able to contribute to what we see as Alzheimer's disease. So there is just sticking with the top row first. And so again, I'm not sure. I was trying to get the laser pointer to show up, but I don't think I'm able to get that. Yeah, sorry. Okay, so no laser pointer, but the top row talking about amyloid protein first. So amyloid is a protein that naturally is produced in our brains and in other parts of our bodies. But what happens in Alzheimer's disease, and this is where, again, a lot of research is trying to sort this out, there is some change that happens in our brains where we are not processing it properly, or it's being overproduced, meaning there's too much of that protein building up. And when that happens, we see what's circled here in blue, this collection of what we call amyloid beta plaques. So you can kind of think of them like plaque on your teeth that the dentist always tells about, when we go for our cleanings. And so it's really, kind of sticking to nerve cells. And as you can see on the right side here, this is showing a neuron or brain cell that has accumulated these beta plaques kind of surrounding it. And what happens is it can cause these brain cells or neurons to die. And that can lead to changes in us being able to, have the normal connections and communication between different parts of our brain. Another very important part of the progression and buildup of Alzheimer's disease symptoms in the brain is also the tau protein that's listed on the bottom here. So amyloid beta plaques kind of stick to the neurons on the outside. Tau protein, when it builds up and creates what we call tangles instead of plaques, these can cause problems inside these brain cells. So there's damage kind of attacking, the amyloid plaques are attacking the brain cells on the outside. The tau protein tangles and neurofibrillary tangles are kind of attacking the brain cells from the inside. And both of these can, really lead to a lot of the brain atrophy or, shrinking of the brain that we can see in the memory centers in Alzheimer's disease. Next slide. So again, another thing to really hammer in right now is, unfortunately, none of the current treatments that we do have for Alzheimer's disease are cures. A cure meaning that it would stop someone from having worsening of disease. That's really what we think of as a cure. And so many of the treatments that we do have can fall into these three categories that are listed here. The first one that I'll go into are some of the older drugs that have been around since the 90s. And so these are drugs that treat symptoms. And so symptoms of memory changes or that can address the changes that we see as a result of the brain cell damage and death that's happening from Alzheimer's disease. The next category is drugs that can change disease progression. I'll go into a little bit about what that means. It's unfortunately still not a cure, but that is referring to these newer infusion medicines that have come about, the second bullet point. And the third bullet point, I'll go in briefly talk about, I know there are a lot of questions about this as well, but I'll talk briefly about some of the medications that are available for treating these behavioral and psychological symptoms that also are very common and can occur at any stage of disease for Alzheimer's disease. Next slide. Great. So now we'll talk about the drugs that treat symptoms. All right. So next slide. So here's another diagram. I'm not going to get too in depth into it, but these are examples of like we're taking a microscope and really zooming in on two different nerve cells that are connecting to each other and talking to each other. And the way that they talk to each other is with these small circles that you see, these compounds that are called signaling molecules. And so there are ways that one cell talks to the other, it releases these signaling molecules, the other one will pick them up with different receptors. And so what we can see here on the left, so the yellow and the green nerve cells here, is that there's a receptor here that's called a nicotinic receptor. I guess that's just a bit more biochemistry there. But what happens in Alzheimer's disease is that the cells that make this yellow molecule, which is important for cells talking to each other and communicating with each other, those cells are the ones that are more likely to be affected by Alzheimer's disease. And so when that happens, there's less of these yellow molecules, that are available for cells to be able to talk to each other, to be able to do things that they need to do, essential functions. And so these three medicines that are listed in the red box here, donepezil, galantamine, and rivastigmine, what they do is they prevent the yellow signaling compound from being broken down so that it can work and continue helping cells talk to each other. So it's, really there to prevent something from being degraded or broken down. And so that's on the left side. On the right side, kind of a slightly different function. It's a different receptor here with the purple and green blue neuron. But this is a receptor that we've seen in other studies, so for some very old studies, that this receptor gets overactive when it's studied in brains that have Alzheimer's disease. And so the thought is that if we can kind of calm this receptor down so it's not as overactive, that can lead to some benefits. And so, I think many folks who've done probably a lot of research, there's been a lot of talk about glutamate. And so this is a glutamate receptor, or that's the signaling compound that's released from one cell to the other to help them talk to each other. And the medicine that helps target that is the medicine called memantine or Namenda. And so again, donepezil being Aricept and memantine or Namenda are some of the two mainstay tablet-based medicines that we have for treating symptoms for Alzheimer's disease. So next slide. And so, the main focus now on sticking to that left side of the diagram from before, these cholinesterase inhibitors, or donepezil, galantamine, rivastigmine. This is something that really should be offered to people when they first get their diagnosis of Alzheimer's disease. There are actually some studies that have shown that there can be some benefit for people that have vascular disease or blood vessel dysfunction issues that are causing their memory issues. But that's maybe only in the milder stages of that disease. But again, this talk is really more focused on Alzheimer's disease. So this should really be offered as a trial treatment for anyone with newly diagnosed Alzheimer's disease. The expected benefit is modest, and what I describe to my patients when I'm prescribing this is that, again, we don't have any medicines, unfortunately, that can restore memory or function that has been lost. But medicines like cholinesterase inhibitors and memantine can sometimes help with improving focus and attention as the symptoms that they can help. And so while that's not necessarily improving someone's memory, by having increased attention and focus, people can sometimes be more functional at doing day-to-day things, so that overall they can have just a better quality of life with that and better ability to interact with others that way. The one of the questions that had come up was asking about when medicine should be stopped. And so, one of the things, I think when I mentioned here on the slide to offer a trial of this medicine, it's something where if someone really doesn't seem to be having a benefit or is having a significant amount of side effects, that would really be when we would stop this medicine. This medicine can be continued even if someone is in the early mild cognitive impairment stage of disease. And I've seen it continued, well into the moderate dementia or even severe dementia stage. At those stages, though, there's unlikely to be a great benefit because there has been such a significant loss of the cells that make this signaling compound that it's unlikely that this medicine would be providing a big boost or assistance to the molecules that are there at that time. So it really is a case by case or family by family decision and discussion that we have about whether we should stop the medication when someone's in a very severe stage. And then I have listed here in the 3 boxes, we have different formulations for these medicines. And so for someone who has difficulty with tablets, for example, patches can be available for these medications. And then, I'll go on the next slide to talk about a bit more about side effects, but there's alternative formulations, short-acting and long-acting versions, so that we can try to make sure someone can get the benefit of having a cholinesterase inhibitor as part of their treatment. If they have side effects with one formulation or one medicine, we can try something else. Next slide. Great. So again,
And Dr. Nee, I'm so sorry to interrupt. Apparently, there's been an error of some sort. There's like been 30 some people on another Zoom link to get into this webinar. And I've been in the background with Jane and Regina trying to get these folks on this call. So I
Can we
apologize,
pause and get them
but
on?
I've been trying to do that. I've sent them links to this. I don't know what the error was to where
Hey,
folks.
Wendy, it's Jeannie.
Hi, Jeannie.
Hi. So Jackie got the link and
Okay.
posted it into the chat on the other site. And I think the numbers are coming up, so everybody's trying to
Okay.
get in now.
I
So
definitely
sorry about that,
apologize.
Lolita.
I don't know how that happened with the registration piece. Sorry.
So I think we can, yeah, but I think people are coming on now, so maybe just like a couple more seconds.
Okay.
Oh, yeah, I'll wait. Yeah, the
Really
number is
sorry about
steadily
that
going up.
interruption.
So sorry.
I got in with the previous link that was sent. The one that was sent out today did not work.
Oh, okay. Maybe give another.
Apologies. I will make sure the website coordinator knows that.
Okay. I guess should I
Yeah,
wait a
you
little bit
can.
longer or
I think you can continue, and the webinar is being recorded, so they can go back and they'll receive a recording of what they missed. Okay.
Perfect.
Thank you. Sorry for the interruption.
Not a problem. I'm glad we can get more people joining now, though. So welcome to everyone who is on the other link. And so we're just talking now about tablet medications that can help with treating symptoms for Alzheimer's disease. And so we're talking about the first category right now, which is the drug class that donepezil galantamine, rivastigmine is. So these are cholinesterase inhibitors. So now, again, to talk a little bit about some of the side effects. So common side effects are mostly gastrointestinal or GI side effects. And I've seen a pretty wide variety of them. Sometimes it's upset stomach. People can have not severe diarrheas. I've seen nausea sometimes. Sometimes people can just have a poor appetite or have reduced appetite or anorexia. And again, many of these side effects can be lessened or even fully resolved if someone takes this medicine with some food in their stomach. And so I'll sometimes tell people if they prefer to take their medicines in the morning to take this after they have breakfast, or if they prefer to take medicines in the evening to take this after they have dinner, just to make sure that there's something in there to help protect their stomachs from this. Another common side effect is actually, I guess, a bit of a strange one for those who may have heard this or when they underwent counseling, at the doctor's appointment or just to the clinicians in the audience. There can be vivid dreams. And so they're not necessarily nightmares, but in severe cases of side effects, I've had patients that have developed nightmares from this. In some cases, getting as so severe where someone actually has acted out their nightmares and was kind of hitting at their wife, just unawares because they were sleeping. Alternatively, people can sometimes have insomnia with the medication. I've sometimes seen that for people who take the medicine at night. And so then I would recommend for people that have these kind of sleep side effects, these vivid dreams, if they're disturbing for somebody, if they're having nightmares or having insomnia, and if they're taking the medicine at night, to switch to taking it in the morning. And sometimes that's enough to resolve those side effects. Another very common side effect is a slow heart rate or bradycardia. And so this is actually an interesting side effect that I think isn't as well known for this medicine. And I have seen some cases where people have been on donepezil or Aricept or another medication of this class, have been found to have a slow heart rate, had a full workup, had a pacemaker even put in. And what was originally found to be the instigator for the slow heart rate was being on this medication. So really be aware of a slow heart rate. Again, slow heart rate can contribute to other severe issues like having increased risk of falling. And so if anybody has any sort of cardiac history, I usually will order an electrocardiogram or one of the EKGs just to be reviewed before starting them on donepezil and have them check in with a repeat EKG with about a month into treatment. Next slide. Great. And so then on the other side of the graph that I had previously shown with the depicting the different ways that these compounds work is this one memantine, which is the class of medicine is called an NMDA receptor antagonist. And so this can be more helpful or beneficial in patients that have moderate disease. So it's not often the first medication to start. But I've seen it used in combination in other practices where someone gets diagnosed initially with Alzheimer's disease. There have been some studies that show there can be a benefit if you take both donepezil and memantine together. But again, a lot of this depends on side effect profiles in terms of other medical conditions that people have and are being treated for as well, for which of these two medications they can safely take. And again, these mostly have modest benefits. And the other nice thing is there is a short-acting tablet. There's also a long-acting extended release tablet, and there's also a patch form as well. And so again, I think that a few people asked about insurance coverage. I think perhaps in reference to these infusion medicines, but typically you'd have to run through the short-acting tablet to see if to then get insurance to cover the long-acting tablet. And then if someone still has side effects with that, then we can try the patch. So that's usually the order of things for having insurance approval for these medications. Next slide. And so again, every one of these medications, because of the ways that they're working on receptors in brain cells and nerve cells, and we have nerve cells all over our bodies. And so there's a potential for side effects. A common one is headache, constipation, and also dizziness, drowsiness, and confusion. So these are typically seen, again, this is usually a lot better tolerated than donepezil. I think for my patients, I've generally seen people have some GI upset issues as a main side effect from memantine. But the key is also to make sure you're increasing the dose to the full dose slow enough to prevent any side effects. Another thing to keep in mind is that if someone has kidney disease, this medicine is processed through the kidneys. So you have to make sure that there's a recent kidney function test number that you can look to make sure that you don't need to have someone be on a lower total dose, just to make sure that you're not irritating the kidneys further with a higher dose of this medicine. Next slide. All right, so now again, we'll talk about drugs that change the progression of disease. And so I'll talk about that on the next slide a little bit. And so, what does it mean to change progression of disease? And so we have here a diagram that shows just overall memory function or cognitive function on that Y up and down axis, and going left to right is time. The green section is referring to someone's memory or function being normal. Yellow is mild cognitive impairment, and red is dementia. And so the black line that we have here is just representing a typical person that has Alzheimer's disease, for example. It's going to keep progressing, and someone is going to, have, again, I guess that this is very simplistic because, as I'm sure many of you know, there's just such a individual factor that's also there. So, not everyone's going to have the same rate of decline. So again, this is just a representative person. But to change disease progression, so let's say at this blue arrow at the middle here, at the point where someone's at mild cognitive impairment stage, let's say they get started on a treatment, and then it can slow down the development of disease. So you can look at the blue line to the right. So everything's just been pushed over a little bit to the right in terms of what their function is. So if you look at the slope, meaning the rate at which they're getting worse with their cognitive function is kind of the same between the two of them, but they're not the individual with treatment is not having the level of memory or functional impairment until a later time point compared to if they didn't have the treatment. So I guess keep this picture kind of in mind as we talk about the infusion medications that are available now. Next slide. So again, going back to kind of one of the earlier slides, and I guess for those who missed it, I'm glad we have this here now as well. So this is talking about kind of the background for how the infusion medications for Alzheimer's disease work. And so again, we have a nerve cell here. And just to show this progression, these A beta or amyloid beta proteins, again, they naturally exist in our bodies and in our brains. But something has kind of kicked off a cascade by which they start to kind of accumulate and clump up when they shouldn't. And the way that they clump up is kind of following this series that you see here, oligomers, longer fibrils that are connected, and ultimately these plaques or amyloid plaques. Again, like I said before, kind of like plaques that our dentist tells us about that are kind of like stuck on our teeth there. And this is what can be damaging to the neurons themselves. So on the next slide, we can see some of the medications that have been developed. These are antibodies that can help stop the development of this buildup of amyloid plaque. And so I do have a gray box here. That's not because it's like a secret medicine or anything. It's Aduhelm or aducanumab, which was one of the earliest monoclonal antibodies. It's not currently available, although I have had some patients that have been on it and are now switching to these other medications. So the first one was lecanemab or Leqembi, And you can see it targets this development of the plaque at two different stages, these intermediate fibrils and fibrils. And then the newer medicine, the one that's also called Kisunla, or every 4-week infusion. That one targets at it targets at the fibrils as well as lecanemab does, but it also can help remove the fully built up amyloid plaque also. So both of these medicines work at two different stages of this development pathway for creating amyloid plaques. I guess an important thing to note is going back to the earlier slide, we talked about how tau can also build up in Alzheimer's disease. And you will note, and just to emphasize here, these medicines are only specifically targeting amyloid. So there's a whole nother protein that builds up those neurofibrillary tangles that can also wreak havoc on our brain cells and neurons that we're not really addressing with this medication. So that's one of the reasons why, again, this is affecting disease progression, but it's not a cure because, again, there still is another protein that's also building up that we're not even addressing with this medication. So next slide. I'll talk a little bit about just how these antibodies work in general, or these medicines work in general. And so here, this is actually a really nice resource. I guess it does spell words a little bit differently the British way, if you don't mind, seeing that while you're reading. But they have some really good patient information about Alzheimer's disease in general, about the medications, and they have a really thorough website with a lot of good pictures like this one for the infusion medications. And so, again, these are not tablets because, we really need to get a sufficient level built up in the bloodstream because then it has to get into our brains. So that's one of the reasons why for right now, it's an infusion, although the latest information is there's now like a subcutaneous shot version of one of these medicines, Leqembi, that I believe is already FDA approved now. So that's more of a maintenance medication for someone who's completed these intravenous infusions first. So, after the infusion's done, the antibodies will get into the brain. And again, not all of them do, which is, again, one of the reasons why the doses are a little bit higher to make sure that we can get enough medicine into the brain. And then what happens is the antibodies, again, going back to the slide that I showed before, they'll bind to those targets that I showed you previously that are affecting and causing damage to the nerve cell. And then what it does is it sort of, sets up a big flag to your own body's immune system saying, hey, I found some stuff here. We need to clear this out. And so that's, it really kind of works with your immune system to then, remove the, as depicted here, these like blue squiggles, which is representing the amyloid there. And so again, the hope is that with this medicine, and actually we've shown in many patients that it's actually very effective. I've seen some patients that have high levels of amyloid based on special scans. And after they've had, 6, 7, 8 treatments, the level is nearly down to 0. So again, it works very well at removing this amyloid medicine from the brain. Next slide. Oh gosh, I'm going a bit long here. So again, the key with these medicines, as I said at the beginning of the talk, is that they really seem to be people really benefit most if we give these medicines to them at the earliest stages of disease. So at this mild cognitive impairment or even mild dementia stage, but really the best candidate for these treatments are people in the mild cognitive impairment stage. There is a extra burden because it's an infusion. So you have to go to an infusion center that knows how to manage patients with these medicines. So there are very few of them compared to other infusion centers that would do, cancer treatments, for example. And the medicines are either every 2 weeks or every 4 weeks. And again, the key to note here is the expected benefit is still modest. And so, like I had mentioned when I showed the diagram earlier, these medicines, they can remove the amyloid that has built up, but whatever process is still causing amyloid to build up and cause damage to nerve cells is still going on. It's not a cure. So this is able to, again, slow down the worsening of memory or slow down progression. And when they looked at people in the studies, in a bit of a best case scenario, it can slow down progression. So look, going back to that diagram that I showed you with that black line being pushed to the blue line, that is about 6 to 8 months of kind of slowing down of that worsening of memory. Okay, and again, here's the 2 medications listed there. Next slide. So at our Hopkins Memory Clinic, this is our eligibility criteria. So these are people who we would proceed with getting the medication, these infusion medicines. So one of the first criteria that's not listed here is that they really need to be very functional. And so not having, again, at worst, having mild dementia. So meaning maybe functional impairment in only a few minor issues, not having too much functional impairment to really benefit most from these medicines. We need to make sure that there's a brain scan or an MRI within the past 6 months to make sure that there's no areas of bleeding or recent strokes, for example. And another thing that, again, we can talk, I guess, if there's time, to see if they have a favorable genetic profile. And that goes back to this genetic test called ApoE. So somebody that has 2 copies of ApoE4 is actually at the highest risk of having side effects from these infusion medications. I'll go into them into the next slide. We can talk about that then. And so, yeah, again, you'll have all these slides to be able to get some of those details. The other thing is that I tell patients it's a commitment to take these infusion medicines. It's 12 to 18 months of treatment, and for, again, either every other week or every month. And so I advise people actually not to travel out of the country. I had some patients who, I guess, someone wanted to go to Mexico for vacation. And I said, well, you need to make sure there's like a hospital or a center that can do an MRI nearby in case you have symptoms or side effects. I was really recommending not to go, but again, that I think ultimately that individual did not go, but that was how our conversation was. There's also additional costs in that it depends how far away you are from your infusion center. There's also the time that it takes at the infusion center and monitoring of you after the treatment that you have. And then we also have patients take an additional appointment in our clinic every 3 months while they're on treatment to be monitored. We have a minimum of 5 scheduled MRIs of the brain to watch out for side effects, but there is also extra unscheduled brain scans in case someone has side effects that we can talk about on the next slide. And so some of the common ones are someone just having a reaction to the infusion, or the reaction to getting an infusion. So that's a side effect that would happen at the actual infusion center. So that's what we're monitoring for, regularly. Some of the most, I guess, popularly advertised side effects are these things called ARIAs, or amyloid-related imaging abnormalities. I think the best way that I describe it to my patients is just calling them areas of swelling or bleeding. And so it's happening because as the protein is being removed, this protein has built up in different parts of your brain, in the brain blood vessels and in the brain tissues. And so as this protein is removed from the blood vessels, there can be leaking or bleeding that can happen. And there can be swelling as the protein is removed from the brain tissues as well. And again, here are some other more minor side effects as well. Next slide.
Okay, you take this box.
So here, I guess it's a bit of a busy slide, but again, it'll be in your handout. So this talks about just the rate of side effects for these healthy participants that were part of the study. And so for Leqembi on the left side here, 30 out of 100 people developed ARIAs, and 70% of people did not. But of the people who did have signs of swelling or signs of bleeding in the brain, 26 of them did not have any symptoms. So it was only found because of the brain scan. And then the profile for donanemab or Kisunla on the right 37% of people had side effects. And again, 31 of them, so a majority of them did not have symptoms. It was incidentally found on the brain scans. Next slide. And so here are symptoms of ARIA. They're very, they can be subtle. And so that's one of the reasons why we tell our patients who are on these medicines, just call our clinic for any symptoms or just feeling funny, and we can kind of talk through it. And then if someone were to have any of these symptoms listed here, we'd actually recommend that they go for a brain scan, a brain MRI. And listed on the right are some risk factors that can increase someone's risk of having these areas of bleeding or swelling in their brain from the medicines. And down here is listed our typical treatment. We would give steroids to help reduce the swelling. If there's bleeding, we would hold the next dose and continue monitoring for resolving signs on imaging before we would restart the medication again. Depending on the severity of the side effect, we may recommend that it's not safe to proceed with more infusions. So that is another potential stopping point for the medication. Next. Okay, so very quickly, there's probably not enough time to do this topic justice, but again, behavioral and psychological symptoms can occur at any time in the course of disease. And so next slide, I have listed here just some of the common symptoms that can happen. Initially, they can be subtle, but they can progress to be very severe and very distressing for, our loved ones with memory issues, as well as care partners and caregivers. And again, next slide, I think the key thing is to look into what non-medical things can be done to address what's happening, because most often pain, sleep issues, dehydration, constipation, and infection, those can most often be the causes for a lot of these behavioral issues that may happen. Next slide. When it comes to medications, though, the most common one that's started is because of the safety profile being the best compared to the other medications I'll go into, is an antidepressant. And so most often it's the ones in the blue here on the left. Those are SSRIs or antidepressants. They also work to help anxiety as well. And again, these can be helpful. I found them most helpful for more mild symptoms of irritability and agitation. The others on the right can also be used sometimes as well. Next slide. So this is maybe some of the more common medications that we see for helping with behavioral symptoms. They're antipsychotics as a class, and that's mainly because they're used for, they can frequently be used in younger adults that have psychiatric issues as well, like schizophrenia, other severe conditions that have similar symptoms like hallucinations, paranoia, delusions. And so we really don't want to use these unless we really have to, because of their safety profile is a lot riskier compared to the antidepressants. Again, they're not FDA approved, but as the next slide goes into the side effects down here, again, there can be increased weight gain. There can be involuntary movements that people can have if they're really sensitive to these medicines. But there is also a black box warning. And so that does talk about increased risk of stroke, heart attack, and death with long-term use of these medicines. So it's mostly seen in kind of the older or first generation medicines that were developed in this antipsychotic class. So the newer medicines that were listed on the previous slide are generally a bit safer than haloperidol, for example. But it's still, the goal here is still to use the lowest dose possible that helps with symptoms for, as short a time as you need to. So next slide. And then there was a question specifically about Ritalin. So I guess in 30 seconds, maybe I'll talk about that briefly. So again, Ritalin or methylphenidate is often used for ADHD. And the thought is that it can help in ADHD, it can help improve motivation pathways in the brain. And there was actually a study done here at Hopkins that talked about how it can be helpful for treating severe apathy in people that have Alzheimer's disease. So again, here, I've had patients that it has been helpful for. I kind of err on the side of the lower dosages and keeping us, if I do increase the dose, doing it slowly over time to make sure that we're avoiding the side effects that are listed here also. So I was hoping to have time for questions on the next slide. I think it's just a thank you. But I guess we will have another session next month where we can maybe go over this and possibly have a question time from this session, perhaps, Wendy. But again, thank you so much for your time, everybody.
Thank you.
Thank you so much, and I apologize to the folks that were sent to another Zoom link today with the reminder. I've addressed that with our website designer. I do want to thank Dr. Nee for joining us today, and because of the great response and the number of questions that came in, we are having her back again next month in February for an expanded talk that's going to go over diagnostic testing for dementia as well as the stages of Alzheimer's disease. So thank you for joining us. This webinar has been recorded, so if you've missed the first 10 minutes of that, it'll be available to you. The link will be sent out and the resources available on our website. So thanks again for joining us, and thank you so much, Dr. Nee.
Thank you, everyone. Bye.
Thank you.
Thank you, Wendy. Bye.